Good evening, everyone, and welcome to Uromet 16. And this is the first session on neurological oncology. And Professor Neville Pereira, sir, and Dr. Angavik Kumarachi, sir, will be doing the examiners. And we will have 6 candidates. And as usual, there will be the sessions will be 10 minutes each. So we had a chat with Dr. Ranga and Professor Neville, and what we thought was we will give a 5 minutes. I'll just give a small reminder so that the Viva can progress, because what we found was that sometimes there were a lot of questions that couldn't be asked due to certain time constraints. So until Neville sir joins, shall we ask Ranga sir to start the Vivas, and Dr. Nishantan will be the first candidate. Over to you, Ranga sir.
Yeah, thanks, Tirina. There's a small something to remind all the candidates. I think you need to time correctly. Try to target your answer and try to answer within 30 to 40 seconds for the given question. Now, for example, I have seen previous sessions, you have been going on for the history examination for a long period, so that you don't get the enough opportunity to proceed with the latter part of the questions. So try to summarize and very focused, targeted answers rather than just hanging around a very vague manner, right? So I will share the screen. Yeah, Nishantan.
Yes, sir.
You have a 23-year-old university student presents with painless left testicular solid mass detected 3 days ago. How do you clinically evaluate this patient?
So, young patient presenting with a testicular lump. My worry is testicular malignancy. So I will assess him with clinical parameters, history, and examination. So mainly I will ask the patient about the risk factors and also the family history and trauma to exclude other causes. And on examination, I will palpate the genitalias, genital examination. So on that, I will compare the both testes, and also I feel the testis which is abnormal, and is there any suspicious features of malignancy. And also I will assess the other, mainly this will be the examination findings, history and examination.
Okay, so how do you confirm your diagnosis?
Confirmation, of course, histological one, but initially we can have a ultrasound scrotum to have some suggestion on diagnosis, and also we can do some blood markers, tumor markers, alpha beta protein and LDH and beta HCG. So if those are elevated, we can have some idea, and LDH also commonly will be elevated. So with those suspicion, clinical suspicion, we can go for a histological diagnosis. Of course, after discussing with the patient, going for a radical orchidectomy will be the option. In that, we can have the histological diagnosis.
Yeah, we'll stop at that point. So scrotal ultrasound scan shows an enlarged left testis with a heterogeneous mass of 2 by 2.5 centimeters, suggestive of a testicular neoplasm. Right testis is ultrasonically normal. So I think you have partly given the answer. Any specific blood investigations that you would perform?
For the tumor markers, level of beta HCG and alpha beta protein and LDH.
Right. Okay. So these are the results. LDH 1040 for 740, AFP 5.1, HCG 1.2. Except LDH, other two are normal range.
Okay, so
what is the significance of the blood test that you have mentioned?
With this blood test, we can have some idea what could be the histological diagnosis. If in seminomas, so normally the LDH will be high, other tumor markers will be very normal. So, and if the LDH is high, then it gives some prognostic idea also. So the either diagnosis and also prognostic information we can get.
Okay. What further investigations would you carry out in this patient, and how do you time it?
Yeah, we can assess to, so since we are suspecting testicular malignancy, we have to do a staging procedure. So for that, we can go for a CT, chest, abdomen, and pelvis to assess the metastasis, lymph node metastasis. So after doing that, as early as possible, since he is a 23-year-old patient, I will advise him to go for a seminar if he's discuss with the patient about the options. And mainly, I will inform him that sperm banking will be better for him and for the future fertility. So after that, inguinal radical orchidectomy will be offered.
Okay. Contrast enhanced chest, abdomen, and pelvis reveals a parietic lymph node mass 2.5 by 4.6 by 6 centimeter. Chest CT is clear.
So the patient is having
So how would you recommend the use of following imaging modalities for initial staging? What is the evidence?
There's no added information can be gathered with the MRI. If there is a CT is contraindicated, then we can go for a MRI. And PET scan, of course, according to the guidelines, initially for the staging, PET scan is not recommended. After doing the radical prostatectomy, so radical orchidectomy for the follow-up, we can, if we are suspecting a residual lesion, then we can do a PET scan. Bone scan, of course, not recommended.
Okay. So how do you treat this patient?
5
So
minutes.
partly I mentioned. Can you complete your answer, please?
Yeah, with the I will discuss with the patient about the management options, mainly the surgical options, and with that I will discuss with him about the sperm banking. After that, I will offer him on the ipsilateral inguinal radical orchidectomy, and after that, that will be the initial management. So patient is having a metastatic disease as well. So after treating that orchidectomy, I will review him with the histology. According to the histology, I will proceed for the management.
Yeah, we'll stop that point. So why do you avoid scrotal approach for orchidectomy? Any particular reasons?
Yeah, it's a theoretical explanation where if we violate the scrotum, then we can upgrade the tumor stage to T4. So because of that, better to have the inguinal approach where we get the control over the vessels first. So we try to prevent the spread.
What is your opinion on contralateral biopsy in this patient?
It's of course still controversy is there. If the patient is having high risk, and also if he is having an undescended testis, the size of the testis is abnormal, then in that case we can offer a contralateral testicular biopsy because if the patient is found a one-side testicular carcinoma, he is more prone to have another testicular risk, but compared to that normal population, slightly more risk, but still we have to discuss and we have to review the patient with the histology. After that, only contralateral biopsy will be done.
So, Nishantan, is there any place for pre-treatment semen preservation, sperm banking in this patient? Particularly, his other testis is normal.
Yeah, most of the time for the fertility, one testis is more than enough. But we might have, if we are in this patient, since he is having a metastatic disease where the lymph node is positive, we might have to go for a chemotherapy in this patient, future chemotherapy. So that might cause a sterilization. So because of that, even though the opposite side testis is normal, we have to go offer him a sperm banking for this patient.
Okay. So this is the histology of the inguinal orchidectomy. A mixed germ cell tumor with predominant embryonal carcinoma with no lymphovascular invasion. the epididymis, tunica albuginea, and spermatic cord were free of tumor.
So the patient is having
Yeah, 1 second. So based on this information, what you had so far, what is the prognostic group? Any idea?
this patient is having this will be the stage 2 disease. Abdominal compartment is involved, so this will be the stage 2 disease.
So how do you differentiate stage 2 and 3? What is the demarcation?
If the I'm quite not sure. If the chest is involved, then it will be the stage 3. Below chest is involved, then it's stage 2.
So what are the available options for further management of retroperitoneal disease in this patient?
So in this patient, we can see is a young patient had a disease. So we can give initially after doing the orchidectomy, we can offer with the histology, we can offer him the bleomycin regime. So with that cycles, with that if he is not improving, still there are after.
So how many cycles? What are the 3 components?
BEP, that means bleomycin and also the I can't remember the other name. Most probably there will be the 6 cycles. So after 6 cycles, we have to reassess the retroperitoneum. If there is any residual disease, then we have to manage accordingly.
Okay, sir. That is 10 minutes.
10 minutes, yes.
Yeah. Tirina, do you want me to?
Yeah, I think so. So if you finish your 2, then Neville sir can do the prostate cancer straight away.
Oh, sir thought we will do change and do Tirina.
All right, okay.
And so can I get 10 minutes to give the feedback, or what is the situation?
Oh, yes, sir. We will have a time for feedback. Yes.
Yeah, expected answers. 1 second. So Nishantan, your time management is quite good, and you gave most of the answers as expected. There are few things you may suddenly, because of the excitement, you have forgotten, particularly the chemotherapeutic agent. It's a very famous regime. So you should know, because that otherwise it will sort of indicate a bit of a bad impression on the examiners. But other than that, most of the answers are as expected, and there were few missing as I expected. Now, so the history, I expected some other things. So the mentioned testicular dysgenesis syndrome, the components, family history, first degree relatives, be more focused on the history. The what components that you are going to ask from the patient. And some of these other things I have mentioned. So examination, mainly the previous surgical scars and the supraclavicular fossa, particularly the left side for the Virchow's knot, and the abdominal examination for masses. So a little bit to expand your answer, the testicular ultrasound scan, this is important to determine whether the mass is intra or extra testicular. That is important. And it's a unifocal or multifocal one. And the volume of the lesion and the testis. And to characterize the contralateral testis, particularly the metacranous lesion, though it's rare, it's about 2.5%. And to identify risk factors for germ cell neoplasia in situ, particularly the volume less than 12. Those are the other important things in your ultrasound scan. So quite correctly, you have mentioned the investigations. So again, you need to elaborate a little bit more. So the users of the tumor marker, you will support your diagnosis. And as you said, histology, there may be some indicative germ cell tumor. And staging, risk stratification, and you can monitor the treatment for relapses and also to detect the relapse, treatment response and the relapses. So this, of course, the timing is best to get this done before the surgical intervention. But the fact that I wanted to highlight, you should never delay the surgery waiting for the CT. In the absence of a CT, you should proceed with the operectomy, and you can plan the CT afterwards, because CT scan will not interfere with your initial management. So quite correctly, I have mentioned the MRI has no major role here. May have a slightly higher sensitivity, particularly if you are suspecting cerebral metastasis with the presence of expertise. Of course, not applicable here. And the PET CT bone scan, not useful in initial staging. And even for the follow-up, you mentioned PET. PET is important, but again, you need to have a significant time interval between your chemotherapy and the PET, because sometimes inflammatory changes can pick up false positive findings. So very important, always these malignancies mention MDT based decision making. That is one of the key terms you need to mention. The other thing you forgot was testicular prosthesis. That is something we expect, particularly in the Western world, which can be either at the same time as the primary surgery or maybe later on. And quite correctly, you mentioned about the semen preservation and nodal management. We separately discussed those, so that's fine. So the reason why do you avoid? It has shown to increase the local recurrence rate. It will upgrade the stage and also increase the recurrence rate. So it appeared that you have read about the contralateral biopsy and things. I particularly asked about the contralateral biopsy at the time of primary surgery. So the answer would be, it's the reason why some authorities, they advocate, because to exclude the presence of germ cell neoplasia in situ in the contralateral testis. However, the incidence is very low. It's about 9%. And metachronous contralateral testicular tumors, its incidence again 2.5%. The morbidity of the treatment and most of these metachronous lesions are low stage at presentation. Therefore, it's controversial. So whatever your biopsy will carry more risk than benefit. So most of the centers, therefore, they don't recommend. But you should have a risk and benefit assessment, particularly as you mentioned. If there's high risk of contralateral germ cell neoplasia in situ, for example, testicular volume less than 12 millimeter or history of cryptorchidism, then you can proceed after discussion with the patient. Semen preservation, we all agree it's definitely yes. The few more things to add your answer. Apart from the treatment, sperm abnormalities and Leydig cell dysfunction are frequently found in patients with testicular tumor. As a percentage, it's up to 24%. They are azoospermic, or 50% can have some sperm abnormality. So therefore, you may be starting with a patient who has already having a sperm abnormality. So that sense, it's very important that you discuss semen preservation as a most cost-effective strategy for possible fertility preservation. In addition to that, your radiotherapy, chemotherapy, they all can have some effect in your fertility, but usually they are reversible. So quite correctly, it's stage 2. And you need to have some idea about TNM staging, not in great detail, but remember here, it's very important you remember the tumor markers, they come into play here. It's one of the malignancies where we consider tumor markers into the staging. So these are some of the prognostic groups. Prognostic groups. Here you could see stage 1, 2, 3. Stage 1, it's easy. They don't have any nodal or metastasis, only any T1 to T4. When it comes to stage 2, it could be N1 to N3. But if you look at the serology, you need to refer this chart. S1, S2, and S3. So they are in the category of S0 to S1. Stage 3, basically they will have M1 or any S category, or sometimes even M0 with S2 and S3, they fall into stage 3. So as there's a small correction, this patient actually falls into stage 3. So stage 3 considered as metastatic disease. Because this patient, if you look at the clinical, it's histologically, it's a PT1, N3, because retroperitoneal mass is 6 centimeter. If it is more than 5 centimeter, that is N3. And serology, LDH level 6.2 times the normal levels. So it becomes S2. Therefore, the patient falls into stage 3 category, which is as equals as metastatic disease. So I ask about the combination. You should know BEP. What do you mean by BEP? Which is the mainstay in treatment here. And number of cycles will vary. Now, certain patients will get 1 cycle, 3 cycles, 4 cycles. In this patient, metastatic disease, usually they will benefit from minimum 4 cycles. So as you said, residual disease will have retroperitoneal lymph node dissection. So that's all, Nishantan, well done. And you can improve. Sir, you want to take over from there, Neville, sir?
Yes. Okay. Right. My question will be on video, Zoom. So
Dr. Taha will be the candidate, sir.
Okay. Right. Taha, you are with me? Okay.
Yes, sir. Good evening, sir.
Good evening. Okay. So let us start with this case. I think probably like in this actual Viva, there won't be any visual aids for you. So you have to listen carefully for what I say, right? So Ranga's
Okay.
one was very good and we learned a lot. But unfortunately, the ground truth, ground reality is that you won't have any visual aids. But I can always send these later on. Let's start. 60-year-old now. Your time starts now. You look like a ghost, but anyway, it's you, isn't it?
Okay. Yes, sir. Sorry.
Not an imposter, no? Right. Okay. Good. Right. So a 60-year-old lawyer referred to your clinic with a PSA of 7, and which was found by the GP on a routine examination during investigation for a suspected urinary tract infection by the GP. And he complains of this, patient complains of hesitancy, moderate spleen, and getting up once or twice in the night. He is hypertensive and diabetic and has undergone cardiac stenting 6 months ago. Okay. Right. Question line is that give me the salient clinical information you would gather during his first interview with you.
I would introduce myself to the patient. I would start clinical assessment with for focused history and examination. Here, my main worry is to exclude underlying prostatic carcinoma. So I will, my focus history will be, is there any risk factors for prostatic cancer, family history of smoking, and other history like such as the ethnicity of origin, and then other metastatic features such as bone pain, abdominal pain, NHS exertional dyspnea. And then I will elaborate more on the lower tract symptoms, as he has voiding symptoms as well as nocturia with the help of IPSS score. And then I will go into detail with his comorbidities, as he has diabetes, hypertension, and cardiac stenting 6 months back, as well as I will carry on with the clinical examination. I'll be focused on general examination, whether he is emaciated, and the general look of the patient. And then I will examine the abdomen for palatable kidneys and the palpable bladder. And then I'll go ahead with the genital examination, mostly with the digital examination of rectum, with suspicious, is there any features of suspicious prostate clinically.
Okay, Right. I think in the family history, what details will you get?
So my worry is the family history is account for 10% of roughly 10% of prostate cancer. So it should be how many generation affected, how many numbers of patient affected. So it should be family history of prostate cancer defined. It should be 3 generations should be affected with more than 3 relatives, or else less. All of them should be less than 55 years.
Okay. The DRE reveals a moderately enlarged prostate with firm, mildly tender area in the right upper quadrant. Okay. And how do you proceed with this patient?
So we had a suspicion of urinary tract infection, and the patient has a history of diabetes mellitus. I know that PSA is organ specific, not cancer specific. This elevation of PSA probably or maybe due to urinary tract infection or prostatitis, and there's a tender area in the prostate also. So I will start him on antibiotic after taking some sample like urine culture and urine full report with basic other inflammatory markers. I will reassure him and I will make sure that patient is compliant with the follow-up. And after a couple of weeks of antibiotic, I may need to repeat the PSA, roughly like 4 to 6 weeks of time to make sure this elevation is not due to infections.
Okay. Now, suppose the PSA remains the same or close to the previous figure, and what else will you do?
So roughly the age-related PSA levels defined by PCPT trial. So he is 60 years. So normally I expect like, so 40 to 45 is 2.5. So 60 years would be 5.5 to 6.5. So this is age-related PSA is high. With the volume also, I can assess the prostate PSA density. So ideally speaking, this patient should undergo a multiparametric MRI, which has a dynamic as well as functional assessment with T2 weighted imaging, DWI, and dynamic contrast enhancement. So in which I will look for any particular areas of suspicion of.
So you will suggest multiparametric MRI for this patient. Okay. So what is the probability of him having a prostate cancer?
So PSA of less than 10% chance of having prostate cancer. His PSA is 7. So PSA of 10 is like 27% of having prostate cancer. It's roughly around 15 to 20% of chance of having prostate cancer with the PSA is 7, sir.
Okay. Right. So how would you confidently confirm or exclude a prostate cancer in this patient?
So the studies like Precision or Promise trials has shown the sensitivity of the multiparametric MRI. So sensitivity is around 97% with MRI, multiparametric MRI done for prostate cancer, comparing the targeted or trust biopsies. So with multiparametric MRI, and after that I'll arrange ideally with transperineal prostate biopsy, which has low high detection rate with low side effects such as sepsis and urinary tract infection. And with that, I will discuss the images as well as the histology in the prostate-specific multidisciplinary meeting with the review of the images, and then I will carry on plan the management.
So you will routinely suggest pre-biopsy multiparametric MRI.
It's
we suggest one. Will you?
Ideally, the pre-biopsy MRI would be better with high sensitivity rate of detection, sir. But if the facilities are limited, then we can go ahead with the trust-guided biopsy also, where the specificity is more the trust biopsy compared to MRI, but the sensitivities and the negative predictive value is more with the MRI compared to trust biopsy, sir.
Right. What measures could you take to avoid a negative biopsy in this particular patient?
Again, number one is Number
doing
one, I
an
can discuss.
MRI, sure. Any other ways of
Number
avoiding
two, the type of biopsy, sir, with it is cognitive or image fusion biopsy. Image fusion biopsy is better, where we can feed the biopsy scan machine with the MRI images with flexible or rigid elastic probe, so that it will increase the detection rate. Or MRI bow biopsy, that is costly, but it also can be done in the MRI room to increase the detection rate.
Okay, will any other biochemical investigation will help you to reduce the number of negative biopsies?
Like PCA3 prostate cancer antigen in the feces or secreted in the urine. If the patient has a high PSA negative biopsy, which can give an idea of repeat biopsy or positive repeat biopsy, sir.
Sorry, I didn't get you. What are the biochemical tests you will repeat?
Prostate cancer antigen.
Yeah.
And there are prognostic markers like oncotype DX, things I can't.
Okay, it's all right.
Sir.
Okay,
Sure.
we'll move on. Right. Do you know about the PSA variants? What do you know about PSA variants in this situation?
So, as I said, PSA is organ specific, not disease specific. It can be raised in benign diseases. So there are variants of modifications of PSA. One is age-related PSA. Number one, PSA density, that is divided by the volume of the prostate gland. And PSA doubling time, normally it should be more than 3 years if it is less than 2 years.
Yeah. May I interrupt? What
Yes.
variant will be helpful in this particular patient in your first visit?
Age-related PSA as well as PSA densities, normally.
Anything else? Okay, let's move on. Right. What would you be your next step if the trust biopsy is negative?
So if the multiparametric MRI is positive, then there is a place, because trust biopsy can miss like almost 50% of the cancers, and mostly in the anterior areas. So ideally, he should undergo transperineal biopsy, 12-core transperineal biopsy. Where the...
Okay, time up?
Yes.
Okay, right. So I think that's the last question probably. Okay, right. So well done. I think we have done fairly okay. Let me make few comments on this your presentation. You are quite confident and you are quite nice and confident in presenting the case and tackling the things. And salient clinical information, when I asked, I think you mentioned most of it. Metastatic symptoms, timing of the PSA, avoiding UTI or any other prostate manipulation except DRE. So DRE doesn't affect the PSA. If you tell that, I think I would be happier, because except DRE, others will affect the PSA, special infection. And then you said about IPS score, and then family history. You mentioned about the hereditary prostate cancer, 3 generations, 3 first degrees. But what about familial prostate cancer? Depending on the family members, involvement of family members, it increases, because hereditary and familial prostate cancer are 2 different things. And also in female siblings, BRCA2 positivity and the history of breast cancer is also a significant thing. And rest is all right, that question. And then when you said moderate enlarged prostate, you tackled it very well. You said that you will repeat it after antibiotics. If you have mentioned the names of the antibiotics, like aminoquinolone and maybe doxycycline for intermediate organisms, if you tell the doses and the drugs, that shows that you are a practical man, and for how long. And then other investigations, when I asked, I was expecting you to say a few things about ultrasonic measurement of the prostatic volume, because those are important when you are calculating the prostate PSA density, and post-void residual and truss volume, and uroflowmetry and renal profile and urinary analysis, because those are the routine tests you do. And ultrasound you have to mention, okay? And prostate volume is going to be useful. And transperineal and transrectal ultrasound, I think you mentioned that, but if you put a couple of sentences in favor of your preference, that is transperineal biopsy, that would have been better. And then comes the probabilities that PSA 4 to 10 is about, say, 26% chance. And when it goes up, that is shown by the PCPT trial, analysis of PCPT trial. And if you mention the downside of the truss biopsy, while you are mentioning it, it's better. And negative biopsy avoidance, I think this part, you have a bit of a lapse in mentioning about the PSA. One thing is PSA variance. Use of PSA variance in this particular case, first encounter, what you can use is only PSA density and PSA density and free to total PSA. So that I expected you to say, because those are non-invasive biochemical. I repeatedly asked biochemical, but biochemical investigations would prevent you from getting not prevent, really reduce the number of. So use of free to total PSA, there are large studies to show that it is useful, but for some reason people are not using it widely. It has been suggested that in one of the studies, and it's published in BJU 2021, you can, just to show that you are reading these things, you can say 2021 BJU publication shows that PSA over 0.25 and free to total PSA less than 2 is very highly unlikely to have a prostate cancer. But this patient, it doesn't apply, because you have to mention that the free to total PSA ratio, and then apply that to this patient. So, and then any non-biochemical PSAs, I expected you to say that PCA3 and it is a prostate-specific mRNA. PCA3 is a urine test, and several studies have indicated that PCA3 test is useful in reducing the number of negative biopsies. More recently, FDA approved the PCA3 for common use by the name of Progensa, and there is a published article in 2016 with a meta-analysis that it helps in reducing negative biopsies. So if the question comes for negative biopsies, add up these things: free to total PSA, PSA density, and a combination of PCA3. And then, of course, the PHI, you could have just mentioned it. I wouldn't have asked details. The prostate health index, and the new variant of that is that the prostate health index density, and which has again been, there are published articles coming up. It reduces the negative biopsies. PHTS predicts the reduction in unnecessary biopsies from 21% to 50% reduction rate. So that definitely going to play a major role in avoiding biopsies, because biopsy, what you said, and is a invasive procedure. So I expected you to give all these points when I asked the question, how would you reduce? That is all evidence-based, right? And PSA variance, you must say that in the first visit, it is useless to talk about PSA velocity and PSA density. Those two variants are there for follow-ups. When people who are in active surveillance, for follow-up, you calculate these variants. But in the first visit, to reduce biopsies or take a decision, these things are not going to help. So that shows that you are not mentioning all these PSA variants in a list in your mind. So you say that. And then again, PROMISE study you have mentioned. If you add to say that it is published in Lancet in 2017, that adds to your, show that you have read about it, rather than just passing by mentioning it. Just say that this PROMISE study published in Lancet in 2017, and precision trial, which is ongoing trial precision, and it's a landmark evaluation of MRI versus truss biopsy, systematic truss biopsy. So according to this, MRI definitely has a place in reducing negative biopsies. In 2019, just know about it, the 2019, the Cochrane review, the latest one, that also has compared MPMRI, the role of MPMRI, and what they say, what is mentioned. So you, at postgraduate exams, you have to give the pros and cons. So PROMISE and precision studies are for MRI biopsies, but this Cochrane review in 2019 shows that there is a possibility of missing high-grade prostate cancers. So, in conclusion, I will not be able to confidently avoid biopsy in that is the final sentence to close-up sentence in high Likert or high pyrite lesions. So, if you say that, I'll be happy. And so that's all I have to say.
Thank you. Thank you, sir.
Thank you.
Yeah, and I will mark you as 7 out of 8.
Thank you, sir.
And Neville, sir.
Yeah.
So I have only one more, that is for the penile cancer. Will you do another prostate before we move on with the penile cancer one? Is that okay, sir?
If you're happy, you can just move into another penile cancer, and then I can come. Or
All right, sir. That's fine, sir. Yeah, we'll do like that.
Are you happy, or I can just?
Yeah, that's fine, sir. Yeah.
Yeah.
Yeah, we'll do like that.
Okay. So the next candidate is going to be Dr. Nalin Ruvinda and Ranga, sir. So you can move on to penile cancer discussion.
All right. Okay. 1 second. Nalin, we'll start. 1 second. I'll share my slides. One second, Nalin. There's a small technical issue.
There's a problem. I can start, but
No, sir. I'll be start. That's fine. Yeah.
Good.
Okay, Nalin. A 47-year-old manual worker is referred to you by one of your general surgical colleagues. He has a penile lesion, appeared to be a malignancy, which is shown here. He gives a history of circumcision 10 years ago, details of which is not available. How do you clinically evaluate this patient?
So I will start the clinical evaluation with a focus history, mainly focusing on the risk factors for penile cancer, specifically in this patient, the history of smoking, as well as the history of any sexually transmitted disease, particularly HPV, and as well as if there is a significant family history of penile or any related geotract malignancies. And apart from that, the clinical examination or focused clinical examination will include a general examination plus a focused genital examination. Now, in the genital examination, I will specifically look for the local invasion or local spread of the disease, particularly whether there's involvement of the corpora cavernosa as well as corpus spongiosum, and the involvement of the urethra. And specifically in this patient, I would look for any palpable unilateral or bilateral inguinal lymph nodes, as well as if there are palpable abdominal lymph nodes as well, if I'm lucky enough. And that will be my focused clinical examination. And from there onwards, I will move on to investigations as well.
Right. So what are the known risk factors for penile cancer? I think you have already mentioned some.
Yeah. Apart from the factors that I've mentioned, having the prepuce or non-circumcised males have a higher risk of developing penile cancers, and it was shown that neonatal circumcision particularly reduce the risk of penile cancer to virtually to 0%.
Okay. So you mentioned about HPV. What are the HPV subtypes commonly associated with penile cancer? Any idea?
Commonly associated subtypes are subtype 16 and subtype 18 with regards to penile cancers.
Okay. Have you heard about any pre-malignant lesions or conditions for penile cancer?
Yeah, so the commonest pre-malignant condition in the penis would be erythroplakia of Curex and Bowen's disease. And there was evidence that even balanitis serotica obliterans also have a slight risk of pre-malignancy. And apart
What
from
is
that,
the modern name for balanitis serotica obliterans? Any idea?
I'm not quite sure, sir. I think it's penile intraepithelial neoplasia. I'm not quite sure, sir.
Okay, move on. That's fine.
And the other pre-malignant conditions would be leukoplakia and erythroplakia.
This lesion clinically does not invade the corpora cavernosa, but invades the corpus spongiosum and the urethra. What do you think? What is the likely T stage at this point?
So it involves the corpus spongiosum, irrespective of whether it's involving the urethra, it goes into the clinical T stage of T2. And the imaging that I would consider to assess the primary lesion, the gold standard would be a MRI of the penis with a pharmacologically induced erection.
What are the disadvantages? Why it is not commonly performed?
One thing is it consumes a lot of time and the availability and the cost. The other thing would be
and the discomfort and harassment of the patient.
Yeah.
So this patient has no palpable inguinal lymph nodes on either side. So how do you image non-palpable inguinal nodes?
So the initial assessment would be an ultrasound, low frequency ultrasound scan, that is 7 megahertz. And if it is not detectable, the ideal would be to go ahead with a contrast enhanced CT of the pelvis.
So your general surgical colleague has already taken biopsies from the lesion. You could remember there's a large lesion.
Yeah.
And what would be the likely histological type?
So 95% of the time, it could be a squamous cell carcinoma. And the less frequent subtypes would be basaloid types as well as sarcomatoid types. And very rarely you can get adenocarcinomas as well.
Okay. So how do you comment on taking a biopsy from the lesion shown? It was a fairly big lesion. So what do you think taking a biopsy from the lesion like that?
So when you're taking a biopsy, you should make sure that you're not taking a biopsy from a necrosed area. And if possible, you should take it from an edge where there's a demarcation between the normal tissue and the abnormal tissue. So make sure that you don't take a biopsy from a necrotic area. That is the main step.
So the penile lesion biopsy histology showed moderately differentiated squamous cell carcinoma. What will determine the prognosis of penile cancer?
So the main prognostic factors would be the local invasion, whether it invades into the corpus spongiosum and corpora cavernosa, and apart from that, the lymph node status. Those would be the main prognostic.
Out of two, you have mentioned which one will be the key factor?
Key factor would be the involvement of the corpora cavernosa as well as the corpus spongiosum. With regards to
any predictive factors? Yeah. And any predictive factors that would determine the probability of having lymph node mets?
That would be palpable lymph nodes. If you have a palpable lymph node, there's a 90% chance that you have lymph node metastasis. But the initial thought was that it was around 50%, which had now been confirmed that it is around 90% if you have a palpable lymph node, that the patient is having a lymph node metastasis.
So imagine if it is not palpable, any predictive factors? that you would consider to determine the risk of having micrometastasis?
I think that would be the T stage of the tumor. And yeah, that is the thing I'm not quite confident on that, sir.
Okay. When and how would you investigate for metastasis in pelvic lymph nodes, or maybe paraiotic and further up systemic mets?
That is, if you have palpable lymph nodes with extra nodal extension, then you have to consider a pelvic lymph node dissection. And when you, it's a stepwise manner. When you start with the superficial lymph node dissection, you find that there is an extra nodal extension. Then you go for a deep inguinal node dissection. And in that also, if you find that a large and extranodal extension is there, then you have to consider pelvic lymph node dissection. So based on your clinical assessment as well as intraoperative findings, I will decide as whether I have to do a pelvic or paraortic lymph node dissection.
Okay. What are the principles of your treatment for this patient?
So the principles of treatment would be to get the local control of the disease and preserving as much as possible the sexual function of the patient, that is to preserve as much as the length of the penis, and then get lymph node control, get lymph node clearance, and as well as treat the metastatic disease as much as possible.
What are the surgical options available for primary lesion, which you have seen already?
So this lesion is particularly confined to the distal or the glandular region of the penis. So I think this is an ideal candidate for a penile preserving penectomy. So with at least 1 to 2 centimeter margin, if I can get a good margin, this is a good candidate for penile preserving.
So can you specify on the margin? What is the margin, minimum margin that you would like to achieve?
I would like to achieve a 10 millimeter margin from the tumor.
How do you manage non-palpable inguinal nodes in this patient?
As I previously discussed, I would like to have an ultrasound scan to see whether there are ultrasonically detectable lymph nodes. If there are, I would go for an ultrasound guided.
No ultrasonically detectable nodes.
Yeah, and in that case, I would go for a sentinel node lymph node biopsy during the surgery. That can be either with the aid of technetium 99 isotopes or methylene blue method. So
any alternative options? Any alternative options?
Yeah, other option would be ultrasound guided pre-detection and specifically going for lymph node dissection.
Yeah, one hold on, please. Tilina, is time up?
Yes, time.
Okay, some more questions. We'll stop there then. So Naren, you want me to give the feedback as any comments from you, sir?
I think he managed the questions very confidently. Do you have any sort of scoring system or marking system to highlight on?
Yes, sir. There are a few things I need to highlight.
Yeah.
A few conceptual, the fundamentals. 1 second, sir.
The thing is that he didn't budge, in the sense that, he didn't get stuck anywhere. But any factual deficiencies, I think we have to.
Basically, sir, the history and examination, it's more or less there. There's nothing much to say. He was complete.
Right.
And examination, again, he quite correctly mentioned the extent of the lesion and the involvement of the corpora cavernosa and things. And the examination of bilateral groins for palpable nodes. One of the key things he quite correctly mentioned. So I asked about the risk factors, the standard risk factors. There are a few additional things apart from which Ravinda mentioned. And again, a very basic question, standard question, the pre-malignant lesions.
So yeah, are you sharing the screen, sir?
Yeah, it's not seen.
No,
I'm
no.
not seeing,
No, sorry, 1 second. Can you see now?
Yes.
yes. No.
I think initial things it's fine. And here, so the pre-malignant lesions, you have mentioned some of them. And T stage, you had a good idea. We are quite confident. Straight away, you told it's T2. So it's important you should have a rough idea about the T stage. And I just wanted to highlight the fact the one cancer where the TNM classification includes tumor grade because it's relevance to prognostic the value. And so you have the option of MRI with artificial erection, you quite correctly mentioned, or even ultrasound scan you can use. You can replace MRI with Doppler ultrasound with erection. But again, they are not quite essential unless you have a doubt, particularly if you are going for organ preservation, planning for organ preservation. So most important thing is the management of inguinal nodes that will determine the survival and the outcome, not the primary disease. So that is one of the fundamental things you need to mention. It's not the local disease control which is important. They can get recurrences, but you can manage and you can cure. But if you mess up with the nodal management, then that will basically kill the patient. That will determine the outcome. So you need to give the due weightage to the nodal management. So the other answer is, now you mentioned about the ultrasound scan, the current guidelines. If you look at European neurology or even the other available guidelines, there is no place for imaging modality unless you have a difficulty in clinically evaluating the patient. For example, obese patient. If you can't clinically evaluate, look for any palpable nodes, then there's a place for ultrasound scan. Otherwise, basically, your management will be determined by your clinical judgment. But as you mentioned, if you are using ultrasound, it has to be a 7.5 megahertz scan. So spot on, 95% squamous cell carcinoma. And I ask about your comments. What do you think about the biopsy? The indications in biopsy now, earlier practice was to, whenever you see a penile lesion, we used to take biopsy, wait for the results, and then go ahead with the primary treatment. Now that the management protocol has changed, most of the guidelines, the indication for pre-treatment biopsy is mainly reserved for two conditions. One is if you have a doubt about the penile lesion. For example, could be something else, penile intraepithelial neoplasia or metastatic lesion or melanoma. So then there's a place for biopsy. Or if you think, if you are planning for topical treatment, a local treatment, topical agents, radiotherapy or laser, then since you don't get a sample, there's a place for biopsy, pre-treatment biopsy. For larger lesions like this, the biopsy, taking a small piece will not change your management. And the recommendation is to get an excisional biopsy of the entire lesion, preferably frozen section at the time of definitive surgery. But of course, in our setup, which is not available freely, that's why we still perform the pre-treatment biopsy. But ideally, it has to be the on-table evaluation rather than pre-treatment biopsy. So the prognostic factors, there are two components. You need to mention about the pathological prognostic factors and the extent of lymph node metastasis. Out of these two categories, I would say the most important is extent of the lymph node metastasis that will determine the patient's survival. So whatever your local nodal management, whether if it is non-palpable nodes, depends on your risk category. This is a good stratification system. You divide the patients into 3 categories. When the inguinal nodes are not palpable, low category, PTA, PTIS, low grade tumors, or G1, PT1. Intermediate would be T1, G2, and high would be T1, G3 and above. So based on this category, the stratification, the low risk category will have the surveillance. The intermediate and the high risk group with non-palpable lymph nodes, they need invasive assessment of the nodal status. So again, the principles based on MDT and as you said, the organ preservation without compromising the oncological control, and then most importantly, the risk stratification based method for lymph node management. So it's a T1, the options available. Probably total glanectomy with reconstruction will be the option for this patient. And I ask about the margin. Now, there is no clear evidence, but most of the studies, they show generally 3 to 5 millimeter surgical margin is quite safe and adequate. And there's another school of thoughts. They show in one study, they show the difference between the grade, the low grade, grade 1, grade 2, and grade 3, 3 millimeter, 5 millimeter, and 8 millimeter margins, depending on the grade of the disease. But generally, 3 to 5 millimeter margin is accepted in most of the guidelines. So it's not 10 millimeter. So as I mentioned, invasive lymph node staging is recommended for intermediate and high risk patients. So you don't waste your time on ultrasound scan or any CT for non-palpable nodes. If you think your patient is intermediate and high risk, straight away you need to go ahead with invasive lymph node staging, which could be either dynamic sentinel node biopsy, or the alternative would be modified inguinal lymphadenectomy. Both are accepted as standard techniques. And then further questions I was to ask about how to perform dynamic sentinel node biopsy in your hands, and I will share this. And then I wanted to ask about if this patient had palpable nodes, how will it change your management? And so on and so forth. So because of the time constraints, I will stop, and I will share for the benefit of the others. So over to you, sir. Ruvinder, quite good, but
Yeah.
few things you need to change, and I think the concept has to be changed.
Yeah. So how do you mark him?
Difficult as a marking side. It's difficult to say. I will give it to you, sir.
Don't give him a 5. You can't give him a 5. So 7 or 6?
Yeah.
7?
Then as you wish, sir. Difficult for me.
Yeah. Okay.
I'm not very conversant with the marking scheme.
I think there's certain lapses there in the knowledge. So you will be sort of hovering between 6 and 7, depending on the examiner's mood, you know. But you told many things, and you were confident, and you were managing.
Yeah, quite good points. He's quite confident, sir.
Yeah,
and very clear, and clarity of thoughts. That's good.
Yes. So I think probably it will be a 6 or a 7. Okay, right.
Okay, well sir. Over to you, sir.
Dr. Nishant Leonapathir will be the candidate, sir.
Yeah, I think. Okay, this comes to me every time. Why is that?
I really don't know, sir.
Okay, good. Welcome, Nishant, again. So I'll just give you another case scenario. And it's a 62-year-old civil engineer with 30-gram prostate on DRE and ultrasound. And DRE finds a firm prostate with a PSA of 8, and undergoes truss biopsy by another unit, and truss guided biopsy, which comes as lesion score 6. Gleason score 6. And he's hypertensive and diabetic, but otherwise fit. So shall I ask what other information do you need from him before you start treatment?
Yes, so this is a 67-year-old gentleman. He came with the symptomatic LUTs, and then I would like to do the risk stratification first. There are a couple of risk stratification systems that we have. DMECO is one of the systems, and the NICE risk category is another system. So I would go with the NICE risk categorization system. So I would like to know know his PSA level and his Gleason score with the grade grouping, and also his clinical stage. If the MRI is available, the MRI stage.
Okay. And how would you stage him? But how would you stage this particular man? And you said that you will use the risk categorization, but how would you stage this man?
Yeah, could I know
DMECO is a risk classification, isn't it? DMECO?
Yes,
Yeah.
sir.
What factors are there considered in the DMECO or NICE?
NICE, we consider the PSA level, so are you asking for the staging?
No, first now you mentioned about DMECO. So DMECO is therefore risk classification.
Risk classification, yeah, yes.
Right. And then what about staging this patient?
Yeah, staging investigations include the PSA as well as the MRI, and also for the assessment of the distant metastasis, we can use the bone scan, and in certain instances, we can use PSMA PET.
Okay. Any other ways of getting any more details about staging apart from these investigations?
Multiparametric MRI.
Okay, fine. So what is the place of parting tables, using parting tables in this particular patient?
Yeah, the parting table is based on examination of histopathological specimens of thousands of radical prostatectomies. So based on the partings table, the results or the pathological results were sort of matched with the clinical parameters, and then they were tabulated, and percentage of involvement of a particular stage can be given with the given clinical scenarios or clinical data. So
once we have staged the T staging, the parting tables will help you to predict
predict the lymph node involvement as well as the involvement of the locally advanced disease.
Okay. So what is the use of parting tables in assessing this patient?
In assessment of this patient, we can actually, with the given clinical data, we can tell him about his clinical stage, which will help us to sort of categorize him according to the risk group, and then to offer him the management.
Will it give an idea about the clinical stage or the pathological stage?
The pathological stage, sir.
Okay, fine. So parting tables, how often are they used nowadays?
Nowadays, parting tables are not quite well used because of the wide availability of the MRI. MRI has been proven to be very highly accurate, especially when you've done it with 1.5 to 3 Tesla multiparametric MRI.
Okay, so that will give you the T stage. But
yes.
When you take the other stages, are there any risk factor classifications which are used nowadays?
Yes, for the nodal classification, there are a couple of risk factor systems. One is the Roche formula, and the other one is the Briganti nomogram, and there's a memorial stone Kettering nomogram. There's one more thing I can't remember, sir.
Yeah. What is Capra score?
5 minutes.
Heard about Capra? Time
No,
up?
5 minutes.
5 more minutes, right? Have you heard about Capra score?
no, sir, no, sorry.
Okay. And Cambridge prognostic group score? Because, all right, then fine. So you said MPMRI, and what other investigations will help in staging this patient apart from MPMRI? That is MRI prostate. But
yeah, MRI prostate, sir. And this patient, I wanted to know his PSA level as well as the clinical stage to decide on further sort of metastatic investigation lineup. So if he's above the grade group 4+3, I would recommend to go ahead with a bone scan as well as the CT chest abdo-pelvis.
fine. So what are your treatment options? What are the treatment options you are going to offer this patient?
So this, what is his PSA? I'm sorry, and his
PSA is 8.
Yeah.
PSA is 8 and 30-gram prostate, and biopsies Gleason score 6.
Yeah. Again, so according to the risk stratification, he falls into the low risk category, sir. So for low risk category, the recommended treatment option is active surveillance. There are many studies which has proven the place of active surveillance, include CLOT study, as well as the sort of active surveillance arm of the PROTECT study. However, he's a relatively young patient, so all options are available. We could go ahead with the radical radiotherapy, and also if he wishes, we can go ahead with
if the patient is not happy with surgery and asks whether he can adopt active surveillance once we have offered the treatment options. Would you continue the discussion?
Yes, I would first explain him what are the sort of treatment goals of active surveillance, and I would explain him the sort of protocol of active surveillance, as well as I would tell him the outcome of active surveillance, again, as based on these 2 studies, mainly the Canadian CLOT study, which shows about 90 to 95% survival advantage.
Right. Does the patient qualify for active surveillance?
Sorry, sir?
Does this patient qualify to suggest active surveillance confidently? What criteria will you go by?
For that, I need to have the MRI findings, sir.
Okay, so MRI finding says it is organ confined cancer.
Yeah, so if it is organ confined cancer, if it is a low risk category, he is a candidate for active surveillance.
Okay, so okay. Final question, I think probably. Patient asked, what do you prefer with evidence? He's an educated man who deals with evidence all the time. So he asks, what evidence is there to suggest active surveillance? You mentioned studies. So can you elaborate on that a little bit?
Yes, the biggest available study is the Canadian CLOT study, which they have analyzed a group of people with the intermediate and low risk category, has been followed up for a longer period, and they have shown there's a 90% survival advantage of these patients, and only a few percentage of people has crossed over to the active management. And that is also, there are a couple of other factors like treatment anxiety and things, the follow-up anxiety and things. Then
studies are there to show that offering active treatment is better than active surveillance.
Active treatment is one of the studies, the SGPC4, that is the Scandinavian group of prostate cancer study, which has shown that there is about 20% cancer specific survival advantage when you treat the patient with radical prostatectomy, as well as the PROTECT trials in the active management group of the PROTECT trial. it is clearly evident that the metastatic progression of the patients who are treated with active treatment is half than that of the patients who are treated with active monitoring. So
with that evidence, would you confidently suggest active surveillance to this man?
I would always discuss the pros and cons of that, sir. As I said, he's a fairly young patient, but I would also reassure that we will be with the stricter protocol. All these studies were done before the active surveillance pathway is there, sir. It is active monitoring pathway. So yeah,
The last
based
question.
Time's up,
last
sir.
question. That is, just tell me what is the active surveillance protocol?
Yeah, active surveillance protocol involves 3 monthly PSA for the first year, sir, and then afterwards the 6 monthly PSAs. And at the first year of his active surveillance, we are supposed to do a trust biopsy, but it has been changed to MRI now, multiparametric MRI. And if that is remains the same, we will carry on the same protocol. And if with the monitoring of the PSA kinetics, and if the kinetics change, if the patient wishes, we can always shift forward to the active management.
Thank you. It's all done.
Time's up, sir.
Sorry for going past the time. Right, I think as usual, I think Nishant tackled it very well. So I think this organ confined cancer that he said, other information, MRI findings to start with, and the clinical staging. Staging, especially the T1 staging is still done with the DRE, though MRI is helping. And the risk classification, the DMICO, which will help to decide on the management plan and the patient's comorbidities and comorbidity scores. So he mentioned most of it. And regarding the parting tables, he quite correctly said that parting tables are no longer used widely because it is based on radical prostatectomy specimens. And this CAPRA score is again now used, and the Cambridge Prognostic Group score and Sloan Memorial, the MSKK is also used. And then there is a recently done, NICE has done a surveillance. So if you can mention it, it's much better, and published in 2020, exceptional surveillance review on this subject. And the summary says that the comparing the parting tables and other scores, CAPRA, Cambridge Prognostic Group, and the Memorial Sloan Kettering Group center scoring are much more useful. So MRI, he mentioned about it, and then about active surveillance. I asked about active surveillance. Royal Marsden qualifying criteria we should be able to apply. Those are the age between 50 to 80, and radical treatment. He should be ready for a radical treatment at any moment. So if he's not ready for any radical treatment, this will not be active surveillance, but it will be watchful waiting. And then the PSA has to be less than 15, and the stage should be 1 to 2. Gleason score should be less than 7, and less than 50%, less than 50% of course should be involved, and 10 millimeter core involvement or less. MRI should be organ confined, and in a 12 core biopsy has to be done. So these criteria, if you just mention that Royal Marsden criteria for qualifying for surveillance, I think I would have been happier. And regarding the arguments for the active surveillance, quite correctly, to start by saying SPCG for that is Scandinavian trial, and then this shows marginal benefit, and with the mean 3 years of life gain by giving active surveillance to these people. And then, but only thing is that the pivot trial, I think you missed out. Pivot trial is also similar to this one, and pivot trial also shows that there is no difference. This is the first trial which shows there is no difference between these things. And it was supported later on by the PROTECT trial, which shows active surveillance, radiotherapy and surgery. They have same outcome. But if you can mention that the BJU article of 2020 April, the Freddie Hamdi himself, the person who did the PROTECT trial, he himself has analyzed these trial sample, and he has found that PROTECT cohort, which he has. So if you tell these things, it shows your knowledge a little bit. It shows that it has shown that there are intermediate and high-risk people who are included in this protocol, the first initial PROTECT trial. So I think they are trying to reanalyze it further. So that is in 2020 BJU. So the PROTECT trial and pivot trial, though they speak against radical treatment for early prostate cancer, there are pros and cons. The NICE guideline for active surveillance, you quite correctly mentioned the guideline. And biopsy frequency should be once after 1 year. And it was repeated in early protocols, but it's been replaced now by MPMRI. And you mentioned all the variables we should go by to do a repeat biopsy. That is changes in MPMRI, or there's PSA density or PSA velocity changes, significant changes in those PSA variants, then you will go for a repeat biopsy, but not routine biopsies. Well done. I will place you at 7, and I am sure you will be sort of margining on a margin of 8. So between 7 and 8.
Thank you, sir.
Okay.
Thank you, sir. Sir, if it is all right with you, can you do another case straight away?
Okay.
So the next candidate will be Dr. Shashi Kumar.
Okay. Right. Good evening. Hello. Yeah.
Good evening.
We're getting to business. Okay. I'm giving you again another clinical scenario. This is a 56-year-old sexually active patient diagnosed with a 60-gram prostate and clinically organ confined cancer, and the PSA of 22 nanograms per deciliter. MPMRI shows bilateral Lickert-4 lesions, and he opts, after lengthy discussion, he opts for radical prostatectomy. What salient information would you share with him while consenting for surgery?
So this patient having a MRI Pirates grade 4, right?
Yeah, for Pirates 4, Lickert-4.
And the Gleason, I couldn't. Gleason?
Gleason score 4+3.
Right. So the patient is willing to go for a radical prostatectomy, and he is sexually active at this point. So first of all, I will explain to the patient regarding the PSA of 22 and bilateral disease. He is coming a category of category of high risk category, about the 22, and considering that, I will explain the pros and cons of radical prostatectomy. Is sexually active, so the radical prostatectomy itself having an impact on the sexual function, mainly regards the nerve sparing nerve function. And at the same time, considering his PSA and high risk, I won't evaluate him with further imaging to make sure the patient doesn't have the further abdominal or bone metastasis. So it needs further evaluation with a CT chest, abdomen, and pelvis, and the bone scan to conclude it is particularly organ confined disease.
Is that okay? Is that all? Okay, right. So what information you are sharing? Okay, right. All right. And then he asked whether he could reconsider his decision and switch on to radiotherapy.
Yeah. Regarding the radiotherapy,
Heard him a lot. He asked whether he can switch on to radiotherapy. What are your views about it?
yeah, if it is organ confined disease, that is proven by the other images modalities, and then the radical prostatectomy and the radiotherapy have the equal cancer specific overall survival or beneficial effect, but it has the radiotherapy itself has its own side effects, and compared to the radical prostatectomy. I will explain the consequences of radiotherapy that include the radiation cystitis and proctitis, and it has its consequence with the erectile function. But here the nerve sparing prostatectomy have some good outcome compared to the radical radiotherapy. So I will explain that part with regards to the sexual function. In the meantime, I will assess his pre-operative sexual function with the erectile dysfunction score, particularly IIEF scores, to have a record of the pre-operative or pre-treatment erectile function.
Okay. And he has heard about brachytherapy, and wants to know whether he's qualified to undergo brachytherapy.
Brachytherapy, it's considered for a low volume and low risk cancer. There is a chance, and it preserves particularly regards to the functional outcome. But in this case, he is a high risk category, and he has the bilateral disease of Gleason 4+3, and he is 56 years old, and he have a particular life expectancy and quite young patient. So I will explain that consequence of recurrence and possible failure of treatment with regards to high volume disease, localized high volume disease.
Right. What are the contraindications for radical radiotherapy in any patient?
If the patient having any previous radiotherapy, then the overall cumulative dose will be high for any other cancer. And if the patient having ulcerative colon, any inflammatory bowel disease, that will aggravate the radiation-induced changes in the bowel. Those are the contraindications for the radiation.
Okay, and what are the contraindications for brachytherapy?
Brachytherapy, then particularly the large volume disease, and
Can you put a cutoff line? Okay.
I don't know how much.
Go on.
So, yeah, mainly the large volume disease will be the.
Any other contraindications for brachytherapy?
Previous relative indication that sometimes the brachytherapy seats may be difficult to insert if the patient has a previous QRP procedure.
Yes. Okay. So last question and last minute. Can you now, if the patient is asking for details of brachytherapy, what are the methods available? What do you use for brachytherapy?
Brachytherapy, usually the radio sheets are implanted into the prostate, and it will if some sort of radiation to the prosthetic gland nearby areas, and that will control the prosthetic cancer. And the side effects of these are minimum, and it is only emitting the radiation to the localized region. And if the patient having
let me know if this time up. Do we have still more time?
Yes, sir. We have 2 more minutes.
Okay, right, fine. Okay, so right. And what are the methods of delivering radiotherapy to this patient?
Yeah, radiotherapy, one form is the intensely modulated radiotherapy with the image guidance. That is the ideal currently, that will in a fractionated manner, that is the ideal nowadays to prevent the radiation related toxicity to the adjacent organ, and according to the tumor characteristic and convex and the concavity of the surface of the and the depth of the tumor, so that can target particularly the tumor. And other than that, conformal radiotherapies and the external beam, the usual standard radiotherapy, but the chance of adjacent involvement are high.
Thank you. Yeah, I think fine. Yes. Okay. Right. I think Sashi's answers are quite okay. There are a few lapses I found that is a short discussion actually. And this is basically kind of, he qualifies for radical surgery. So the question itself says that we have already decided to go ahead with a radical prostatectomy. So your first question was, what information, salient information you would share with this man who is consented for surgery? So I think you should be conversant with a few figures, because he will definitely ask, what are the chances? So the main problems are having problems in the trifecta, achieving trifecta. So you must start by saying that achieving trifecta, there can be problems. So I will explain that. Urinary incontinence, what are the chances? Roughly, what is the chance of urinary incontinence?
That is 5% at the end.
You have to know about these figures, because otherwise you won't be able to counsel him this way or the other way. Because this is important, because otherwise later on he will come and say that you said that there's hardly any chance of having this. So it was 50% chance in overall studies, overall chance, 50% chance, and it can go up to about 70% transient sphincter weakness and blood instability. But at the end of 1 year only, you have to decide whether he is really incontinent, and especially after the basic, simple and advanced urodynamics before you intervene. So if you tell that, it's much better. So this first question is the main part of this question. So 50% chance is there. And long-term incontinence, how do you define long-term incontinence? It is using 1 pad a day. At the end of 1 pad a day. 1 pad a day, it is classified as incontinence. But this excludes the stress incontinence. So intervention is generally done according to NICE guideline. AUA is the only option, and that will be offered after 1 week. Okay, and other options are mild options are bulking agents and male sling, bladder urethral slings, and then you have to mention about this erectile dysfunction and how many the percentage you have to tell them. There is also around 50 to 60% depending on the nerve sparing. But if there's no nerve sparing, this goes up to about 90%, 90 to 95% in non-nerve sparing. Right, almost certain that everybody will get it. But nerve sparing, it is unilateral. It is about say 50% if you spare at least one side. So that figure you have to have it in fingertips. And generally, you can keep on saying that, if it continues, I will give this treatment also. So that will, you will be continuing the discussion in that case. Because what my question was, what information will you share? So you have to give the complication and then tell what we are going to do that. That is exactly what we are going to do with the patient. And then infection, bleeding, stenosis, and anesthetic complications. infection, bleeding, stenosis, stenosis, they all fall into about 10%. So try to remember that. Other complications are 10%. And then what about some survival data? So you have to share some survival data with him. And how long will he be PSA free? Okay, and metastatic free, and overall survival is going to be how much? What is the figure? You have to put a figure into that. So he will ask. Otherwise, the educated person will ask, how long will it take for this cancer to come back? So how do you answer that? It will be PSA free for overall this type of patient for 75% PSA free. But it will be metastatic free at the 5 years, 90% of time, and overall survival is about 95%. So you give some figure. Even if you have forgotten the figure, you say that I will be discussing with him the survival data. So, and then the PSA recurrence, you have to mention about the PSA recurrence, few words about it. And PSA recurrence is in 10 years, about 30%, and starting on the 3rd year, and clinical disease will develop after the PSA recurrence. Clinical disease will develop after. So if I'm not supposed to interfere, but otherwise, if I'm given the chance, sometimes we put these sideline questions. From the PSA recurrence, it will take 8 years for the disease to come back, and it will take another 5 years to die of that disease. So you have a 13-year interval or a window. So you have to tell that also to the patient that there is a possibility of that after surgery, and then you have to tell about the adjuvant, neoadjuvant to adjuvant therapy, with the place of adjuvant and neoadjuvant therapy in case post-operatively you find that there is a locally advanced disease. So you have to talk about, we'll be doing it in the next one, about the adjuvant home radiotherapy and the place of adjuvant hormonal therapy. And in this question, I am not expecting any details about that, but we have to mention that fact. You will be sharing this information with him. And so that is it. And when it comes to he can reconsider radiotherapy, I think you should wholeheartedly agree, because that will leave you from getting a local recurrence and all the problems. But you have to explain him about the comorbidities of radiotherapy. That complications includes hemorrhagic cystitis, which can be in 1%. 1 to 2% of people, it can be really life-threatening. Radiation cystitis, which is now not very common because of the conformal or IMRT, conformal radiotherapy. Hematuria and proctitis in 20% of people. And the leg edema, apart from incontinence and ED, leg edema in 6% of patients, right? And there's a possibility of a second cancer. So erectile dysfunction also will be there after 1 year. There's a 30 to 60% chance of, because of the pelvic fibrosis, there is a chance of erectile dysfunction as well. So this information has to be shared with him. So I asked at the end contraindications for brachytherapy. Previous TURP, generally there's only the capsule is there, so you can't place the seeds. So that is one contraindication. And large prostates, as you correctly said, over 50 grams. The radiation doses are not well distributed, and previous pelvic irradiation is another contraindication. You mentioned that, and very high Gleason grading, group grading about 5, and very high IPSS score. That means there's obstructive symptoms. Those are contraindications for brachytherapy. So with these little bit of factual deficits, I think I'll place you around 6. Okay.
Thank you, sir. Do you have any other cases, sir?
There is one more, two more really. Time permits. Ranga has finished his, so you can.
Yes, sir. Basically, that's all I have prepared.
Okay, right. That's fine. Then I will go into this other case scenario. Are there any candidates left?
Yes, sir.
Right.
Next is going to be Dr. Muni Priya.
Okay. Okay. Good evening, Muni.
Good evening, sir.
Okay, right. Here you are. This is your man, 66-year-old man presenting with PSA. You can jot down if you want the details. PSA of 18, and trust biopsy revealed 4+4. Gleason score is 8, and 12 out of 18 cores were positive, and core length was 9 millimeters. DRE revealed a firm left lobe and right-sided hard nodule. And the MRI done, this is actually not mentioned about the pre-biopsy or post-biopsy, but MRI shows MRI showed pyrite lesion on the pyrite lesion breaching the capsule with bilateral intralobe pyrite 4 lesions, multiple bilateral pyrite 4 lesions. Bone scan was arranged and it is negative. And rest of the metastatic survey, distal metastatic survey is negative. Got it? Right.
Yes, sir.
How would you stage this patient?
According to the given information, sir, its patient is in high risk group, and according to the MRI findings, capsular breach is there, so it is most probably T3 lesions.
Okay, so T3.
Nodal status and other things are negative. So because of T stage is T3 and nodal stage 0 and the M0.
Okay, fine. So considering this situation, what would be the best treatment for this patient?
When I consider the age, he's 66, and the MRI, according to the MRI findings, bilateral intralobe extending to the capsule. So I would say the best treatment modality would be external beam radiation radiotherapy plus adjuvant.
Yeah, okay. So you want to push him for radiotherapy?
Yes, sir.
Right. What is the place of radical surgery in this patient?
Because of the capsular breach, the high chance of morbidities compared to the radiotherapy. So because of that, radical prostatectomy is in lower down compared to the radical radiotherapy, sir. But when we consider the life expectancy of this patient, still we can consider the radical prostatectomy after discussing with the patient with the probable complications, especially the sphincter incontinence and the erectile dysfunction. If the patient is happy to tolerate those things, as well as second thing is the possibility of the margin positivity, which need the adjuvant radiotherapy, follow-up radiotherapy. So that is the most important thing I think I want to consider when I discuss the radical prostatectomy for this patient.
Okay, fine. So what do you know about radiation methods?
Radiation methods, there will be a high dose and a high dose radiotherapy, and the other thing is the
okay.
Yeah.
Right. Okay, fine. Don't worry about it. And your radiation colleague will be there. But don't trust anybody 100%. Have some idea about it. You have heard about, okay, let's say, he strongly opposes radical surgery, doesn't like radiotherapy. And he says if there's a chance of some sort of a chance that he can escape with surgery or getting cured by surgery, he would go for it. Okay. So you mentioned about giving him post-operative radiotherapy.
Yes, sir.
Right. So what evidence is there to support that?
In PROTECT trial, mainly consider the radiotherapy versus radical prostatectomy arm, but later on there are I can't exactly remember the name. The spirit or one trial is there which is given the radical prostatectomy followed by radiotherapy. It shows there is a reduce the local recurrence and the little benefit from the overall survival as well.
Okay, right. So you will not advise him to undergo radiotherapy. Or will you advise? There's advantage or disadvantage.
Radiotherapy
what is the problem of giving radiotherapy?
The problem of giving radiotherapy is mainly the difficult to decide go for a second later on go for a radical surgery. One thing is, the second one is the radiation induced.
How this man is, sorry to disturbing, this
Yes,
man
sir.
has undergone surgery now, so he has
All right.
opted for
Okay,
surgery.
sure.
So this is regarding post-operative radiotherapy. So are you in favor or not in favor of giving radiotherapy?
I'm in favor of giving radiotherapy for post-operative radiotherapy.
Fine. Okay. So then when you are giving radiotherapy, how will you time it? When will you give radiotherapy?
One thing is I want to wait on mainly I will discuss in the multidisciplinary team meeting with my colleagues of oncologists as well as the radiologist also including, because of the recurrence and the pathologist also important to discuss in that meeting. And with my oncology colleagues, I will decide the exactly time period. So most probably it would take the healing period is we have to consider. So because of that, all the wounds should be healed. So, and other thing is to exclude the possible infections, and there should be a good urine flow, and we have to remove all the catheters and stent if we have put prior to surgery prophylactically. So most probably after 8 weeks, I would recommend to start the radiotherapy.
Okay, so in 8 weeks, right. Okay, fine. And then what is the place of hormone therapy or ADT, androgen deprivation therapy, in this particular patient? Now he has opted and undergone radical surgery.
In androgen deprivation therapy, there is a we can I can't remember the trials which they have done for, and I can't remember this.
No, what I'm asking is that what is your present view about giving it? Should we give it or we shouldn't? Is there any place for hormone therapy or there's no place for hormone therapy? Very yes or no answer.
There is no place for androgen deprivation therapy for after the radical prostatectomy, sir.
Okay. Right. So that finishes your line of questioning. Okay. Right. I think we are finishing, coming close to 9. So, right. So let us assess you. So you are quite correctly said that this is locally advanced tumor. So you have staged this patient correctly, and this involvement of capsule is will put him into what T stage? What stage will it be? Yeah?
T3.
Or
T3.
T3. Okay. And so it is locally advanced cancer. So it's a high risk locally advanced cancer. So best treatment will be, as you argued for radiotherapy. That's quite right. But unfortunately, there is after explaining everything to the patient, if the patient opt for radical prostatectomy, we cannot completely disagree and say no, not no for to him. And especially if I have not given, if the post surgical staging, is T3A, you find all these things after, then you have already done the surgery. So you have to think of what adjuvant treatment you are going to give. So the question line was on adjuvant therapy, and about radiotherapy you have explained, but he has had bad experience, but so that's why he has refused it. But when you asked about radiotherapy, know the basics of it. That quite correctly you said conformal radiotherapy, IMRT, and the high dose and low dose things come from brachytherapy. It is not for but for radiotherapy, it comes standard radiotherapy or hyperfractionation of radius. So in brachytherapy, high dose, the low dose one you use palladium or iodine. They are seeds, so they are placed permanently inside the prostate. You will see this X-ray. There are dots there all over the place. And then a high dose one is used iridium tubes. Those tubes are, once they are irradiated, they are placed, you remove them, so there's nothing left inside the body. So just know those basics of it. And then hyperfractionation, there are some studies have gone on. There's a thing called 3-chip trial. And oncologists, all oncologists know about it. 3-chip trial in 2016 has shown that rather than giving, the usual fractionation is how much? 70 grays in 37 fractions. Okay, but if you reduce it to 60 grays for 20 fractions, that's called hyperfractionation. It gives the same results. So this 3-chip trial, which is published, it's a very large trial, shows that. So confidently say that. So low dose, high dose in brachytherapy, and hyperfractionation and standard dose for external beam radiotherapy. And the last part, I think you little got stuck there. I think at your level. So post-operative radiotherapy, right? The study you have to mention is what? Who study? BOLA study. Okay. BOLA study, which is a randomized control trial published in Lancet 2005. Often mentioned trial. Okay. That is early versus late radiotherapy, EBRT, post-prostatectomy. And what they say is that it improves the PSA recurrence. It has not come yet by 50 to 70%. But there is no overall survival benefit in that. Okay. PSA recurrence is prevented. So because of that, BOLA trial is pro for giving early radiotherapy. But then came the other studies which nullified these findings, not entirely nullified, but challenged these findings. What are the two studies you have to mention? One is radicals trial, that is called radicals RT trial, which has given its final verdict in October 2020, very recently. These are all ongoing studies. The radical series is for hormones and radiotherapy both. So this particular study is called radicals RT, radiotherapy trial. So this trial includes the hormonal treatment as well. So it has shown that there's no benefit in giving adjuvant radiotherapy in comparison to the policy of salvage radiotherapy. So the radiotherapy has two names in here. That is immediate post-operative radiotherapy, as you were suggesting, and salvage radiotherapy is when the PSA or biochemical progression is detected. So these two types of things, BOLA trial suggests that give early, okay, salvage radiotherapy, but then later on, these radicals RT shows that there is no benefit of giving it. okay, early. So we must say that according to the latest findings of this radical SRT trial, timing of radiotherapy after radical prostatectomy is done, and it is published in Lancet 2022, and it shows there is no benefit of giving immediate radiotherapy. And place of hormonal treatment, I asked, and again the often quoted study is what? The Stampede trial. Stampede, that is giving hormonal adjuvant. Okay, there's an ongoing early prostate cancer trial program is there, and there are about 8,000 patients involved in this. And basically what you have to know is what is given. It is bicalutamide. Giving bicalutamide to standard care protocol. If you add bicalutamide 150, there are in locally advanced cancers, irrespective of the primary therapy, whether it's with radiotherapy or surgery, there is a benefit of adding this hormone therapy. But again, this trial is not completed yet, so you must know that, but mention about Stampede trial. Okay, so 3 trials in post-operative adjuvant treatment after surgery for locally advanced tumor that you have to remember are the BOLA trial, and it's published in Lancet, and Radicals RP radiotherapy trial plus Stampede. And so that's the last part. You got stuck with the trials, but now I think after having so many Uromets on trials, and you were suggesting 50 trials, and I was counting, I can't find more than 35. So, so I think you should have these often mentioned trials in your fingertips, not the details, but what is the latest situation of the trials. Don't mention about trials which are very old, more than 10 years old. So current situation of trials. So remember those 3 trials. Okay, done. So I'll place you around 6. Yeah. Early 6. Right. Okay.
Thank you, sir.
Almost 9 o'clock now, isn't it?
Yes. Can I ask the question, sir? That yes, sir.
Yeah.
Regarding surgery, sir, that is it contraindicated for T3A disease or T3B disease to consider surgery, sir?
T3A, still there are people who will go and do the radical prostate. T3B, which involves the surrounding structures more, that is seminal vesicles and things like that. Seminal vesicle involvement is generally considered as a contraindication, but capsular breach itself is not an absolute contraindication for surgery. Still, if there are no node involvement, there's no extension. Only thing is that when you are counseling the patient, you have to look at the pyrids and Likert stage and Likerts, and then if there is a pyrid 4 or 5 lesions in the periphery, you must tell him about inability to do nerve sparing. There are bilateral. But if there are organ confined pyrid 4 lesions away from the capsule, you can always say, I will try to do a unilateral nerve sparing. So you have to talk about nerve sparing. But capsular breach itself is not a contraindication for radical treatment.
Yes.
Okay.
And then this intermediate and high risk patient, they talk about extended pelvic lymph node dissection, sir. Is it?
Yes.
Is it a skin like bladder or?
I think that is basically for the bladder, the extended, super extended, and lymph node dissection. But again, high risk patients, if the lymph node you have to do a operator fossa lymph node sampling, or actually lymph node excision. And then if it is a high risk patient, now you are right, they advise to go on an extended one up to the pelvic bridge. But going up to the aortic level is still not, pretty sure. But for high risk patients, yes, the operator fossa nodes are alone is not enough. And if the others are positive, then it speaks more in favor of giving adjuvant treatment.
Yes, sir.
Yeah. I mean, you can share the knowledge with the others, whatever you.
Yeah, so the guideline says up to the level of the bifurcation, sir. And the advantage is, of course, there is no the survival advantage of lymph node dissection in prostate cancer, whereas there is a significant in bladder cancer. And the other advantage is if it is pathological node positive disease, you can give adjuvant androgen deprivation therapy, as you mentioned, sir. So that is the indirect advantage.
Yeah, that's true. So I think just remember those levels. Okay.
So Surangi, sir.
Yeah.
So in staging purposes, CT abdomen pelvis, in which occasion do we recommend? In intermediate and high risk group, or
yeah, I think the guideline says that if it's a high risk group, yeah, intermediate and high risk,
yeah. And if there is any multiparametric MRI, still do you do in intermediate group?
Intermediate group, I think it is not that useful, best of my knowledge. But high risk group, which is falling into nearly a metastatic, micrometastatic situation, I would go for that. What do you think, Nishanta? What are the guidelines like?
So the guideline says, guideline says unfavorable intermediate group, which is ISAP grade 4+3 and above, which has given us the only sort of category. But there is a sort of concern about the how would you sort of comment on the node positivity in the MRI. But again, I think in most of the countries, as we heard the other day, like the places like Australia, if it is ISAP 3 and above, they go for a PSMA PET, which will serve as both the nodal as well as the any other metastasis as a single mode staging.
Yes. PSM, I think CT, I think is more accurate in a way. So I think if it is is it in the NICE guidelines? That
no, sir, no, it is not in the NICE guideline. I think because of the high cost and the availability across the UK, I think it is limited to many centers. They have the common FGG.
Yes. Unexplained PSA recurrence and the PSA rise. I think you will be considering PSM, prostate specific membrane antigen CT. Yeah. So I think it's not finalized. I think the place of PSMA CT, PET CT.
This BOLA trial and radical, they talk about P3, PT3, N naught, M naught. If the margin is positive, then do we have to give immediate radiotherapy or follow up with PSA and if up to one, sir?
Yeah, up to 1. I think that is the thing. If it is, give it when it is over 0.5 and before it becomes 1. Because the BOLA trial says that it's immediate radiotherapy. But the thing is that there has been going on, these other studies have been going on, and then actually they were publishing very sort of positive and very happy publications saying that no more immediate radiotherapy after radical prostatectomy for PSA recurrence. So I think delayed, what is called salvage radiotherapy, is now the going to become the standard rather than immediate radiotherapy. So you can mention this radical SAR-T and the stampede for hormone and radical SAR-T, which is still ongoing. So it's a phase 3 trial by Professor Christopher Parker and published in Lancet in 2000. So read about it.
Yes, sir. The other advantage of this trial, the radical SAR-T, is that immediate post-op radiotherapy will sort of significantly contribute to the urinary incontinence and other comorbidities. Yes. By delaying it, this can be avoided. And the other thing to add, sir, as you said, when you do the imaging, when the PSA becomes 0.5 or so earlier before the 1, so the other advantage is the lesions which may not be seen in the restaging images will start to appearing after PSA above 0.5. So that is another advantage if you want to look at the FTG PET and the other imaging.
Right. So
So a few things about the about the benefit of
Yeah.
the trainees about the lymph node staging of the penile cancer. Because there are I worked in one of the centers in UK, so there are about 3-4 centers in UK which manage the penile cancer. So one of the centers happened to be our center. So what they do is, just for the benefit of the trainees, so if the DSNV is mainly important for the clinically non-palpable groin disease, as we know that about 30% of the but more than 25% of the people with non-palpable, clinically non-palpable lymph node disease, they will have occult lymph node metastasis. So as Dr. Ranga correctly said, the lymph node status is the sole sort of prognostic indicator of the penile cancer. So you don't have to miss that. So we have to sort of go for an invasive staging. That is what is recommended if it is sort of a non-palpable disease. So if there is non-palpable disease and if the patient is having penile lesion, as Dr. Ranga said, if it is quite obvious, we are not sometimes wasting time with the biopsy, because biopsy might come as necrotic and negative. So we go for straight away, we go for a sort of partial penectomy plus dynamic sentinel lymph node biopsy on the same day, same setting. So we asked the patient to come to the radiology department around 10 o'clock in the morning, and we booked the surgery around 2 o'clock, 3 o'clock. So they, at about 10 o'clock in the morning, they give sort of peritumoral radionanocolite as well as circumpenile radionanocolite. It's given in a sort of intradermal manner. And then patient will take a scintigraphy. There's an immediate film, which will show the immediate draining nodes, which is supposed to be sentinel nodes. And then also there are other delayed nodes, which will be seen in static images around about 20 minutes, 1 hour, 2 hours. And what they do is they map all these and they put it onto the PAC system. And at the same time, the hot nodes, the initially drained hot nodes, they put a marking with a sort of permanent marker. And then the patient, after about 4 hours time, patient will come to the theater. So in the theater, what we do is, as we know, the DSNB, the sensitivity is around 90%. So what we do is we add patent blue. So patent blue is something like methylene blue. So what we do is we just give the patent blue subdermally in circumpenile manner in the shaft, proximal to the lesion. And then we ask the sort of anesthetist to give the anesthesia, and we scrub and come. So this patient has been marked after DSNB. So patent blue is given. So then we sort of take the Geiger marker and then Geiger counter, and then find out where the hot spots are, the hot nodes are. And on those marked areas, we open up. And then at the same time, we can see those, most of the time, these nodes are blue because of the patent blue. So then we take the samples, we do bilateral, because again, as you must be aware that there are about 25% of the penile cancers cross the other side. So there is bilateral crossing at the inguinal level. So you have to do both sides. So you do that. And once you do that, send the samples, then close it, and then you do the partial penectomy. Then we'll wait until the sort of biopsy results come. And if the sentinel nodes biopsies are positive, then we can go for a radical inguinal lymphadenectomy. It could be either video endoscopic inguinal lymphadenectomy, or it could be open inguinal lymphadenectomy. But if the DSNB is not available, like in our setting, what we do, even at places like Anuradhapura, is we just give the patent blue, and then do a modified, what is called modified radical inguinal lymph node dissection, as Dr. Ranga said. So you need to know about a few things about the Dassler zone, because in our settings, it is quite easy. You find out the Dassler zones. There are actually the 2 medial quadrants of the sort of a site which is marked at the SFJ. And then you take out the 2 medial quadrant as well as the central quadrant, which is at the level of the cross. So you take out all the nodes because we don't know which one is sentinel, and then you send. And if they are positive, you proceed with the groin dissection. So that is usually what is done. So same thing with the DSNB, sort of to a certain level we can achieve, but the DSNB is superior with a 90 to 95% with the patent too. So that's just practical experience. So yeah.
And Nishant, just to add to that,
Yes,
now earlier there had been a practice when the palpable nodes are there, the clinicians, they used to treat with course of antibiotics and then wait for the nodes to resolve, and then fine needle aspirations, cytology, and all these things are not in practice, no longer recommended.
Yes, I think the figures are quite important.
Yes.
About 90% of the palpable lymph nodes are clinically palpable nodes are positive for metastasis. And about 30% of people usually present with lymph node metastasis. And about 25% of the unilateral lymph node metastasis have a contralateral metastasis also. And about 25% of patients with inguinal metastasis, lymph node metastasis, have a unilateral or the ipsilateral pelvic lymph nodes. As you know, the point is pelvic nodes, they don't cross. So if the inguinal nodes are positive on one side, the same side, the pelvic nodes are positive and they don't cross. But if the inguinal nodes are positive on one side, there's a 25% chance that the other side also have inguinal lymph node metastasis. So if one side is positive in the DSNB, what we do is we do a radical lymph node dissection and find out the exact pathological node staging. If it is PN2 or more, then we proceed with pelvic lymph node dissection.
Nodes.
Yeah.
And in addition to that, Nishant, they need the imaging for the intra-abdominal metastasis.
Yes, that's where I think Nalin, when you ask, when you ask for a CT, I mean, the ultrasound for node dissection is very, very low sensitivity unless the patient is obese. So if the patient is not obese, you don't waste and wait, you don't do the CT, you go for a invasive groin assessment. And if that is positive, you go for a full CT cap.
Yeah, that's quite useful discussion, really. I think we should have a kind of a review lecture on this penile and testicular cancers by one of you all. Was not to update. So are we going to
yes,
wind up or yeah?
I think we have gone a little bit beyond time, but I think it was a very interesting discussion and it was very informative. Like a lecture at the end, so that's why I also didn't disturb. I must thank Professor Neville Pereira, sir, as always, for the great scenarios and the very informative, updated questions. And I must also thank Dr. Anga Vikramarachchi, and I heard he was very ill a couple of days ago and he had great difficulty preparing for these cases. So great appreciation to you, sir, for all this effort. You're doing this for us. And once again, all the volunteers and also Dr. Nishant Patrana for organizing all this, and everyone else who was involved in this Uromet as well. And once again, our sponsors, CIPLA, for providing support for this venture. So I think I'm not sure whether we will have another discussion in midweek for clinical trials. But even if we don't, I think next week we will meet for the next Uromet Viva sessions. Thank you very much. Good night and see you all next week.
Thanks, Thank you.
Thank you. Have a
very much.
pleasant
Thank you.
weekend.